Good morning, everyone. Thank you for joining PHCA for today's webinar, Emergency Preparedness and Life Safety Code Update. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1.5 continuing education credits for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. Today's webinar is being presented by Charlie Schlegel, Director of the Division of Safety Inspection for the Pennsylvania Department of Health. Charlie will be giving you an update on the Life Safety Code requirements used for state licensure and federal certification, along with an overview of CMS Emergency Preparedness rules. Common deficiencies related to emergency preparedness and life safety will also be discussed, and how to avoid these deficiencies and ensure compliance. Your learning objectives for today include an overview of CMS Emergency Preparedness requirements for long-term care facilities, a review of common emergency preparedness deficiencies, and finally, a review of common life safety code deficiencies. I'll now turn the webinar over to Charlie.
Thank you, Wendy, and good morning, everybody. So we have a lot of slides here, and you'll find that throughout the presentation, there are some slides that are here more for information, so when you get the materials later, you have that in hand. You'll find that some of the slides we'll kind of skip over, but it's really so that you have that information at a later date. So when you're working on your emergency preparedness plan, or if you want to come back and look at some of the information, you can do so. So we're going to start off, as Wendy was saying, for the overview. We're going to talk about CMS Emergency Preparedness, some of the common emergency preparedness deficiencies, and then we'll give a life safety code update. And then the CMS rule change for renovations and new construction going forward on resident rooms and bathrooms, and then some common life safety code deficiencies at the end. And like we were saying, feel free to ask questions. You'll see my contact information is at the end as well if you have questions later. And for those of you going to the fall conference, I'll be there as well in case you want to discuss some of these items then. So emergency preparedness from CMS, what they're talking about is trying to establish national emergency preparedness requirements for Medicare and Medicaid participating providers and suppliers to plan adequately for both natural and man-made disasters and coordinate with federal, state, regional, local emergency preparedness systems. So this was their main goal. It's something they've been working on for quite a few years, and last November, we'll talk about was the start date. So it's still relatively new, brand new requirements from start to finish that everybody is trying to get that grasp on. Here's the actual Code of Federal Regulations, 42 CFR 48373, and really what it says is a long-term care facility, which we'll emphasize today, it must establish and maintain an emergency preparedness plan. And sounds kind of simple, but as those of you who are used to CMS requirements and familiar with emergency preparedness, there's quite a bit to it. And you're going to hear me say must be reviewed and updated annually quite a bit because it's really stressed by CMS throughout their requirements. So the plan must do the following. Must be based on and include a documented facility-based and community-based risk assessment, utilizing all hazards approach, including missing residents. So obviously missing residents is bad, so that's something that they added to specifically for nursing homes to make sure that we don't lose anybody. Include strategies for addressing emergency events identified by the risk assessment. And some of these things that you're hearing with risk assessment, community-based risk assessment, facility-based, we'll discuss those definitions later to get a better understanding of what they mean. And address resident population, including but not limited to persons at risk, the types of services the long-term care facility has the ability to provide for an emergency, continuity of operations, including delegations of authority and succession plans. So you might be part of a corporate system, but what we're trying to say here is not every long-term care nursing home facility serves the same type of patients. We might have some that specialize more in rehab, some that specialize more in vent patients. So we really have to make sure that our plans are specific to our type of facility and what residents we're caring for in those specific facilities. We're still talking about the plan. So the first part is making that plan. So you have to include a process for cooperation and collaboration with your local, regional, state, and federal emergency preparedness officials' efforts. So we want to really want you to reach out to your community emergency preparedness, and we're going to have contact information later to show you who those folks are. But it's just we're really going to stress throughout this that it's not just something that's facility based, done just at your facility. It's reaching out, being part of the community, figuring out where you fit into the community emergency preparedness plan, and then working from there. So once you have the plan, you're going to have to develop and implement emergency preparedness policies and procedures based on the plan. And again here, they have to be reviewed and updated at least annually. This is something we're going to talk about later as well. We'll get more in detail in reference to the fact that your policies and procedures must address the following. And it talks about provision of assistance needs for staff and residents, whether they evacuate or shelter in place, to include food, water, medical, pharmaceutical supplies, alternate sources of energy to maintain temperatures, to protect resident health and safety, and for the safe and sanitary storage of provisions, emergency lighting, fire detection, extinguishing alarm systems, sewage and waste disposal. So we're really going to get more into this later, because there's lots of questions on the alternate sources of energy in reference to emergency power and generators, and we have the 71 to 81 temperature range for for residents, and can we maintain that in an emergency? So those are things that we'll get into more specifics later in the presentation. The policies and procedures have to address a system to track the location of on-duty staff and sheltered residents in the long-term care facility's care during an emergency. If on-duty staff or sheltered patients are relocated during the emergency, the long-term care facility must document the specific name and location of the receiving facility or other location. So this, really goes back to making sure, if there is an emergency and we're evacuating, especially if we have to evacuate, maybe some folks are, maybe having to go to the hospital, some are maybe going to another nursing home that we have an agreement with, or a local church, or other type of facility, that we really have to have a system in place to make sure we know where everybody is going, and make sure that we're able to follow them through and make sure that they're still getting the care that they need. Safe evacuation from the facility. So a lot of folks already have an evacuation plan before. This is just provides some more specifics. So we need to make sure there's the consideration of care and treatment for those that are being evacuated, what our staff responsibilities are, transportation. So how are we getting them from point A to point B? Identification of those locations. These are locations we really should try to plan for ahead of time. Things may change, going forward, and you might have to make some adjustments. But it's always best to have those identify the locations where you can evacuate ahead of time, and so we know where we can go and make sure that they have enough space and support for the residents. And then primary and alternate means of communication. So you're going to see this a lot, where you have the primary and the alternate means of communication. So it's going to be extremely important. I was a little excited yesterday when I came into the office, and our phones and computers were down here in Harrisburg. So luckily the webinar was not yesterday, or we would have been scrambling a little bit, because we had no means of communication other than my cell phone. So sometimes there's just those days that you come in and your primary means is down, and you definitely need that secondary means of communication. A means to shelter in place for resident staff and volunteers who remain in the facility. So for sheltering in place for a certain amount of time, we have to make sure that it's safe for those folks. And system of medical documentation that does the following, where we still want to protect our medical information the best that we can, and stay within the rules and requirements for such. The top one here is one that we'll definitely talk about later on, especially when we talk about common deficiencies at this point, and that's the use of volunteers in emergency and other staffing strategies, including the process and role for integration of state and federally designated healthcare professionals to address surge needs during an emergency. So it's really having a policy and procedure in place to discuss volunteers. That people are coming to the facility saying, hey, I'm a doctor over here at this hospital. Is there anything I could do to help? I'm a nurse. I drive a school bus. Do you need me to drive these people for you? Is the facility going to say, yes, check in over here and we'll get your name and information and we'll use you as a volunteer? Or are we going to say, no, we don't want any volunteers. We're just going to use the folks that we have, so that we have a better idea of who's responding and who's evacuating our residents or caring for our residents. And then if there's some type of issue where maybe something like the CDC has to come in, you want to be able to have a policy and procedure in place saying, okay, there's this type of emergency. The CDC is coming in, they're going to do their investigation. We're going to make sure that this is how the process is for when they come in, and how we sign them in, make sure everybody's aware of who they are, and how we'll cooperate with that type of event. Development of arrangements with other facilities and providers to receive residents in the event of the fact that you can't continue services at your facility. We talked about that before. And another one that we'll really talk about later and provide more information on is what happens when there's an emergency declared by the President and the Secretary of the Department of Human and Health Services with Section 1135. So we'll talk about those 1135 waivers. So once you have your plan and your policies and procedures, then you're still working on the documentation for the emergency preparedness by making your communication plan. And again here, once we get it, we still have to every year at least review it and update it once every year. Your communication plan is going to have all this information on it. So sometimes you might have to do updates more than once a year. Unfortunately, sometimes it's difficult to keep staff. We have the same issue here. I wish we could keep everybody, but sometimes they get better offers elsewhere to go work for different facilities or different jobs. So as the staff change, we need to update that. The folks that are providing services under arrangement, the different positions for the residents. So it's this information all has to be in your plan and at least updated annually. Then you're going to need the primary and alternate means for your facility staff. So not only do you have that primary communication phone number or means to get a hold of them, but you also have the alternate means. And then you're going to have the same for your emergency preparedness contacts in your area. And that's something that when you see the contacts later, we can make sure you add that to your plan. So we have the method for sharing information as we can for the continuity of care, and then making sure that we safeguard that medical information. So we're still in the communication plan. So you need to provide information about the general condition and location of the residents. So we evacuate. We're talking before. Some go to the hospital. Some go to another facility. So we need to make sure that we're keeping track of those residents, making sure that they're getting the care that they need, and we know where they're at. A means for providing information about the long-term care facility's occupancy, needs, and its ability to provide assistance to the authority having jurisdiction, the incident command center or designee. And this is really when you're getting together with your local emergency preparedness folks, and you can reach out to them and make sure that if there are any needs or lots of resources that we have within the state, that we can help out as well. At one time, if it was winter time and the power goes out in the building and you have no means of heat, or your heating system goes down, and we're asking somebody to run to Walmart and buy all the space heaters in the building, the Trine heater building, when there's other resources out there that somebody might be able to bring in to provide that for you, or cooling devices in the summertime. So it's very important to have those contacts and make sure you update your needs so that you know that you can reach out and get that help. Once we have all that, we're going to do the training and testing program. And with this first year, there's a lot of things in the plan that we're looking at, but going forward, hopefully it's really just updating the plan and then making sure you're following your training and testing program. And here again, has to be reviewed and updated at least annually. That's a little bit easier because we can do the after-action review and use that as our update. The training program has to do all the following. So the initial training, so you make a new plan, we have to tell everybody what their role is. So we have our staff. If you're going to use folks that are providing services under arrangement as part of your plan, if you're not using them, if you're using volunteers, if you're not using them, whoever's in your plan needs to understand what their roles are. And that's something that when we go out and do surveys, we can interview staff and say, okay, what is your role per the plan? And make sure that they're familiar with that role. Then you have to provide emergency preparedness training at least annually. So you do that initial training, get everybody trained up, and then we want to set up the annual training program where you're going to do the continuing education. You want to maintain documentation for all that, and we always talk to you in reference to having it readily available. So make sure that if you have a corporate office, they can keep a copy in corporate. That's fine, but make sure every facility has their information on site. And then, like I was saying, demonstrate staff knowledge, and that's something that we can do through the interview process. This is the one area that's been getting a little bit confused through this first year. So the first part is you have to participate in a full-scale exercise that is community-based, and then we'll talk about when a community-based exercise is not available. Then it could be facility-based. And if you actually have, unfortunately, if you have a natural or man-made emergency where you have to activate your emergency plan, you can use that. So you don't have to do another one. So that's good for 1 year. So if you have an actual emergency, you have to evacuate, put your emergency preparedness plan in place, or your sheltering in place for a couple of days, maybe with some of this flooding that we've been having, or it's going to be super hot again today, so it's going to be stressing the air conditioning and the humidity. So there are some things with loss of power, but this is again the first part, and that's the full-scale exercise, and they want it to be community-based. But with this first year, we'll talk about some ways to use a facility-based if your local group is not doing a community-based drill at this time. So in addition to that, you have to do a second full-scale exercise that, if you have some options. So if you want to do a full-scale exercise, you can do another one again, but this time it could be facility-based. So it could be just something at your facility, and you do an exercise with your staff. Most folks are doing a tabletop exercise where you're going to have your key leadership sitting around a table. Maybe some folks are either calling in, or you could be doing some type of Skype webinar. And a lot of times I'll show for the folks that like Big Bang Theory, kind of a clip from Big Bang where they have Sheldon has different notes on different emergencies, and then they pick one and they run through what would happen and add a scenario. So very much the same thing. If you go through your risk assessment and you have some scenarios based on likely risks to your facility. You live along the river, it could flood. So we have a flooding event here in Harrisburg. Anytime it seems to be, we can even have traffic issues because for some odd reason, whether anything happens, everything comes to a standstill here. So it's one of those things where, depending on where you're at, you want to make sure you have some exercises that are based on that. And then what you do is, go through, make sure everybody understands what would we do if this happens? How would we handle this? We can't get supplies in. Some of our staff are on this side of the river, on the other side where it's flooding, they can't get in. So how are we going to provide the care? And then you make sure that your plan addresses everything. And at the end, and this is where we get into the update, where you can easily do the update annually, is you need to do an after-action review. So if there's something you did great, that's wonderful. You say, hey, we did really well at this. If there's something we say, wow, we did this exercise and our plan didn't address this part, then maybe that's something that we need to look back at our plan and add. It's not that we have to rewrite the entire plan, but maybe we have to, just add a section on something where we realize there's a little bit of a gap. So emergency standby power systems. So this is something that we'll talk about a little bit later, but I just want to bring it up. There's a lot of questions on generator location, emergency power system, what systems we have, on-site fuel source. So we'll talk about those when we get to some of the frequently asked questions. So CMS, they put out survey and certification letters. They changed the terminology a little bit recently, but these are letters that explain what their requirements are and then how the facilities are to comply and how the state agencies are supposed to survey. So this first one is, it's readily available online. You could Google it, find this information, and it has a lot of information that'll help you out with the FAQ document. And there's an entire web page that they can take you to that's dedicated just to the CMS survey and certification requirements. So it's a really good link to have. That way, if you have questions, you can go straight there. So on the website, you're going to find your state healthcare coalitions, what facilities, definitions, frequently asked questions. A lot of the information that I have here, in the slides are based off of the website. And when we're talking about resources, I know it comes up a little bit small here, but hopefully we can, once it gets sent out, you can zoom on in. But it shows you here all the healthcare coalitions and where you would fit in the state, and then who your contacts are. And then the next slide I'll show has their contact information. So what you really want to do is make sure that you're reaching out to these folks, these different healthcare coalitions, and getting with them. And they have resources to help you from everything with working on your plan, if you have questions on your plan, to how to do drills, what type of drills you should do, what your risk might be in your area. Instead of reinventing the wheel, they can either point you in the right direction, get you involved with some other folks. So these are very important resources for emergency preparedness. They're saying really small again, but what you have here are email addresses and phone numbers, and these folks reached out to me a little while ago before I did some other presentations, asking me please put our information out, tell everybody to contact us. So feel free to give these folks a call. I think they have their areas broken down here, so you can see the different areas, who the contact information is, and they can, like I was saying, in an emergency, they're definitely a great resource. They'll know where we might have some extra generators that we can maybe get out if your generator's having issues, or if you need some help with heating, you need help some cooling, evacuating. These folks are there for that. Another survey and certification letter, 17-21-all. So CMS was just putting out more information, and they really wanted to clarify that by November of last year, November 15, 2017, that all facilities are supposed to already be in compliance with the CMS Emergency Preparedness rule as of that date. So here again, it's underlined, but it's pretty much saying that because it has an implementation date of the 15th, they expected every facility, whether you're nursing home, hospital, any of the affected facilities, to be in compliance, already have your training and testing done by November 15th, 2017. Same thing here again. So it's just one of those where they kept on explaining that if we're not in compliance by then we decided for non-compliance. And here's where they're encouraging facilities to seek out, participate in the community-based drill, and that's where you're going to reach out to your healthcare coalition and your local emergency preparedness folks and say, when's the next drill? How can I get involved? Because community-based is not just your facility, it's where you fit into your community emergency preparedness plan. And here's what we talked about early in reference to, and we've heard this especially in some rural areas where the community is saying, okay, I understand November 15, 2017, but we're not doing our next community-based drill until August 2018. So what can you do in the meantime so you don't get cited is you have the ability to do a facility-based drill just with your facility, but document who you contacted, specific reasons why they couldn't do a drill, to show that, hey, we did reach out to do a community-based drill. Our community told us, here's the information where I reached out. Here's who I reached out to. Here's where they told me that we're not doing a community-based drill until this time. So in the meantime, we did a drill that was just based on our specific facility and just our facility response. So that was an option, and still is, if your community is still not having that drill. But the important thing is to really make sure that we document. And then the last resource that I have for an S&C letter is 17-29-all, and this is some good information. It's only 74 pages, which is relatively short for CMS, but it's their interpretive guidelines and survey procedures. So it is the questions that the surveyors are supposed to be asking, what they're, what we're looking for when we go out to the facilities. So if you go through and you read that and you see that here's the tag, here's what we need to comply with that tag, here's the questions that the surveyors are going to be asking us. All that information is in this document. So the emergency preparedness tags, like we were saying before, they're brand new, top to bottom. So they're E-tags. So you have your health tags, which are the F tags from Susan Williamson's group of the Division of Nursing Care Facilities. You have your K tags, which are your life safety code tags, and now we have the E tags. So you have 3 separate tags. They are going to work the same as your other tags. So the same time frames for correction, the same principles on scope and severity, everything's going to be the same. The only difference is that you'll see that it'll be a designation of an E tag. The CMS decided that they be let each state figure out if they're going to have the health or life safety code surveyors do the emergency preparedness surveys. And in Pennsylvania, where you have facilities that the life safety code goes into the buildings and does the surveys, then they're going to be doing the emergency preparedness tags with the consultation or help from health where we need to do so. So here's the part where we're going to, we'll hit on some of the definitions, but here are a lot of the slides that I just wanted you to have as reference that are coming right from the CMS website, so that if you have any questions, you can always go back onto what a lot of their definitions are. But there's going to be a couple that that we're going to hit on, with starting with an all hazards approach. So you'll see that they have quite a long definition of all hazards approach, and it focuses on identifying hazards and developing emergency preparedness capacities and capabilities that can address those, as well as a wide spectrum of emergencies or disasters. The approach includes preparedness for natural, man-made, or facility emergencies that may include, but not limited to, something that's care-related, equipment and power failures, interruptions in communications, including cyber attacks, loss of a portion or all of a facility, and interruptions in your normal supply of essentials such as water and food. So this is something that is really wide in scope, and they want you to have the this all hazards approach and try to think of everything that it really relates to your facility. A lot of folks are going to electronic medical records, so we do have to worry about cyber attacks. Unfortunately, those watching the news, we've had another shooting, so we have to worry about active shooters. It's something that you hopefully would never have to worry about, but it's something we do have to prepare for. So we really have to make sure that we have the all hazards approach. And we were talking about facility-based before. So facility-based is specific to the facility. So it is something that is happening just to your facility is responding to. When you get into community-based, that's where you're part of a group that's all responding to a community-based event. The full-scale exercise, you see that it involves multiple agencies, jurisdictions, disciplines, integration of operational elements involved. You'll see they talk about boots on the ground response activities. And in this example, they use hospital staff treating mock patients. So it's more than when we talked about the tabletop where you're going over and talking through. It's really hands-on doing a full-scale exercise. Your hazard vulnerability assessments. Some of these you're more than welcome to do your own, but a lot of times in your area, it could be your local emergency preparedness or maybe the FBI already have some of these done for you. So you can really reach out and use that information to base yours on instead of creating one from scratch. So there's a lot of good resources out there for HVAs. Another quite a long definition, but this is what they consider for the risk assessment. But we're going to move on to staff. There's a lot of questions on what they mean by staff, and they define, CMS defines the term staff, referring to all individuals that are employed directly by the facility, and then the phrase individuals providing services under arrangement. That means services furnished under arrangement that are subject to a written contract. So, when we're talking before about making sure we train staff and those types of things, there's the definition of staff versus individuals providing services under arrangement. And then here's your tabletop exercise. Kind of gives you good information about that. So there was a lot of frequently asked questions. We're just going to kind of go over a couple. The first couple we're going to say pretty much the questions are, is there a specific format that I have to have, the plan in? Does it have to be done a certain way? And what CMS is saying, there isn't a specific format. We just want you to have the information available. If somebody has a good format, feel free to use it, but you don't have to. Everybody doesn't have to have the same. Same question here. It just came in multiple formats. The question here was, do we have to have our emergency preparedness plans approved by like a state agency or your local emergency preparedness? Well, you want to have them involved, your local emergency preparedness, and if you have questions, you're more than welcome to reach out to your field office and say, I have questions about about my plan. Is there any help I can get on this question? There's no formal stamp of approval that you have to get for official sign off. They say here, but it's definitely something that you want to have them involved to make sure that you're fitting in with the community plan, but there's no official sign-off. Definition or intent behind the word community, and what CMS answers is they did not define community because it's different throughout the nation. So even if you're in an urban area, and maybe Philadelphia, you might still have areas in Philadelphia that are more community. So different communities within the city, whereas rural areas, you might have much larger areas covered under the same community. So that's really when you want to reach out to those contacts we gave you for the healthcare coalitions, to make sure that you're fitting in with the local community plan. So this one's kind of an easy one. They're asking what happens if you don't comply, and if you don't comply, then you get cited just like you would for any other deficiency. So are there any penalties? And it's just the same thing. It would be any deficiencies are cited just like you would have any health or life safety code deficiencies, same time frames for correction. Resources. So we have these webinars. We can, if anybody has questions, we have the ability to ask questions here, and then you have my email contacts, but there's also all your healthcare coalition folks and local emergency preparedness. There's lots of resources out there if you have questions. We talked earlier about the definition of staff. Training. So CMS has had some training. It's mostly webinars. They do large-scale nationwide ones, so it's pretty much just sticking to their slides and doing that type of training. So hopefully with these, if there's some things that suggestions on what might be good to be addressed at maybe your fall conference for PHCA, that are something I can definitely talk about then. Feel free to let me know. Okay. So now we're going to get into, this is where we talked about the generators. CMS at first was saying that our emergency preparedness plan requires that certain facilities have generators. They've backed off of that a little bit in reference to make sure you have generators available. But what you're going to find in Pennsylvania is you folks are really good at having generators. The issues that we run into sometimes are what the generator can power. So we'll have some facilities where they're newer, they have had a recent upgrade, and they're going to be in much better shape because their generator can power a lot more things. Where we have some older facilities, or maybe we haven't had that chance to upgrade our generator, that might just do some of the basics with lighting and fire safety features, and we don't have extra outlets and heating or cooling or those types of things on the generator. And what you're going to find is we really have to make sure that what you have available at your facility is demonstrated in your plan. So if you're in your plan, you're going to say, I'm going to shelter in place no matter what for a week, then you need to show us how you're going to be able to provide cooling during the summer, days like today, or heating in the winter. And if you can't demonstrate that, then we're going to say, okay, then your plan and your facility, what you have, don't comply because they don't match up. So if you do have a generator that maybe your common areas, you have the ability to heat and cool there, we can at least keep residents there, then we can say, yes, okay, we understand, great. Maybe if you have a natural gas generator and the emergency is that the natural gas line has ruptured and you're not getting fuel, then, we should have the flexibility built into these plans to say at any time, if the emergency dictates that we're going to start our evacuation process. So, what a lot of folks are doing is they're kind of writing that into the emergency preparedness plan, that our goal is to shelter in place, but, at a certain time, if decided by, our key leadership, then we'll start our emergency evacuation plan. So here again is more questions. Do we have to install one? Are we required to have one? And really what we need to do is make sure that our plans meet what we can do, what our facility can handle. So if we have a generator that can handle a lot more, our plan could be more robust in how we're sheltering in place. If our generator emergency power is not as robust, then we're going to have our plan such that we're ready to evacuate when we can't keep those temperatures. We don't want to be the other year in I think it was Hollywood, Florida, where the nursing home had the folks die from too much heat, especially when there was a hospital not too far, right across the street or down the road that could have provided care for those folks. So one, they should have been able to reach out. Two, they really needed to understand their limitations of what their system can provide for their residents, and then base their plan off of that. So, here's a good question in reference to, how much food do we need to have, how much medical supplies. So, a lot of times we have the provisions in place, with our vendors saying that, we're a healthcare facility, we need to, we need bread before you send bread down to the Turkey Hill or the Wawa, the Sheets. So we really need to make sure that, we have that understanding, but also build in that flexibility, saying that if the emergency is such that it's flooding and we just can't get supplies in, then, somehow we're going to have to figure out how to start that evacuation process, because we're not able to maintain that supply. HVAC systems and alternate source of energy. Sound like I keep repeating myself. I just want to stress, make sure our plan is tailored to what our system can provide. We don't want to say we're going to shelter in place for 3 days, and instead of 81, it's 85, and in the building it's 87. It's getting too hot. We need to monitor the temperatures. Understand that once we start getting to the upper levels of the temperature ranges, that we need to get folks to a safe place. And you'll see that they just keep asking the question in a lot different ways, but CMS is pretty much answering quite a bit in the same. So here are some examples, not limited to what we talked about before. So here are some things. We do have some earthquake areas in Pennsylvania. I believe Reading is an earthquake zone, so they would need to have earthquakes. Tornadoes, hurricane, flooding, yes, we've had that issue. Fires, unfortunately, yes. Cybersecurity, single facility disaster like a power outage, some type of community disaster, infectious disease outbreak, and then, like we were saying before, unfortunately, we have to also worry about the active shooter. So here we're going to talk about top 5 deficiencies from November 15th to August 8th. And here's that first one, the 1135 waiver. So we'll talk about that. Volunteers and staffing, testing requirements. You'll see subsistence needs, and then the plan based on an all hazards approach. If you want to concentrate more on the bottom, this is actually the deficiency tag you see on 2567. So the top is more the basic information, and the role on the bottom part says the role of the facility under a waiver declared by the Secretary in accordance with Section 1135 of the Act and the provision of care and treatment. So the big information here is it's not saying that you have to have 1135 waiver now. It's saying you have to have a policy and procedure in place that demonstrates how you're going to ask for one and implement one in the time that the President of the United States and the Secretary of DHHS declares a national emergency. So if you send one in to CMS now, they're going to send it to me and tell me to call you up and ask you what type of emergency you're having, because we're not aware of any emergency that's going on in your area. So it's definitely something where it's not that you have the waiver in hand, it's how you would get the waiver, and we have some information on resources about how to do that in a couple slides here. So the second one, volunteers and staffing, I talked about this before. It's just having something written as a policy and procedure on the use of volunteers in an emergency and how you're going to integrate state and federal healthcare professionals. So it's here again, it's just having a policy and procedure in place on how you're going to handle these. This one, kind of understandable. It is the testing requirements, and it's either a lot of times we're confusing facility-based with community-based, or we're not doing the second drill, or we're not doing the after-action review. So we have to remember that we have the initial training, we have the annual training that's ongoing, and then we're going to have testing where we have the full-scale. The goal is to be community-based unless you reached out to your community officials and they said, no, we're not doing one at that time. Then you document that and do it facility-based. And then we have to do the second, which is either a full-scale exercise or the tabletop. And then when we're done, that's when we take a look at how well we did, and then we make sure we document that we analyzed our plan and we updated it as needed. So assistance needs for staff and patients. So a lot of times you'll see down in item number 1 at the bottom what we talked about before, which is on the next slide here. It's really having the plan match what we have available for the residents. So if we're saying we're going to shelter in place for this time, we're going to ask, okay, where's your food, water, your medical supplies, how are you going to heat and cool? Emergency lighting, that's something that should already be taken care of with the Life Safety Code. Fire detection, extinguishing alarm system should be good. A lot of people forget about sewage and waste disposal. So, if there's some kind of emergency, we also have to be able to make sure that we're taking care of that as well while we have residents sheltering in our building. And then the all hazards risk assessment. So that's where we just have to make sure that it's documented using all hazards approach, including missing residents, and it's one where, like we talked about before, it just needs to be tailored to your facility. We're trying not to get in down into is this really an issue? But if you're along the river and you don't put down that you have to worry about flooding, then yes, we're going to say, hey, what's going on here? You should add flooding. But it's one where you really want to make sure that it's not a corporate-wide one for all your facilities. It's one that's based on your facility and its location and the residents you care for. So the 1135 process guidance. So there's a whole website. It tells you, what a waiver is, how a waiver is declared, the things that you can ask for in a waiver. So this is a good resource to write that policy and procedure, saying you don't have to put that Charlie is going to do it, but could it be the nursing home administrator upon declaration of 1135 waiver will evaluate what waivers are being offered and send it in through this process. And that's how you document that and not get cited for not having this issue. Not that you have to have the waiver in hand, because you can't get a waiver unless there's a national emergency. And you'll see, here we're discussing that again, and that this is something when the president declares a disaster emergency, that's when you can get an 1135 waiver. All right, so we're going to skip a little bit to the 2012 Life Safety Code and Healthcare Facilities Code, which is NFPA 99 and NFPA 101. So as we know, that was effective July 5th, 2016. So I'm going to go through some of these slides a little bit quicker so we can get some of the information at the end. The importance of the July 5th date is really if you're an existing or a new building. So we look at your plan approval date. If it's before July 5th or July 5th or after, you get surveyed under the new or existing Life Safety Code requirements. And then we started using the 2012 Life Safety Code on November 1 for survey purposes. And then if you really like reading CMS requirements, that's where you can find them. And they did a really neat thing with the tags. So I encourage everybody to have a Life Safety Code NFPA 101 book at least in your facility. You don't have to have the big handbook, but for $85–90 you can get the paperback version. And it's really important because what they did is they changed the tags. So K18 used to be deficiencies for corridor doors. They changed it to K363. K29 was hazardous areas. Now it's K321. And the reason they did this is so that you could open up your code book and see what you got cited for. So if you got cited for a K363 during your survey, you can open up your NFPA 101, and if you were built plan approval before July 5th of 2016, you would go to Chapter 19, which is the existing healthcare occupancy, and you go to Section 3.6.3 is corridor doors, and it tells you what the corridor door requirements are. So you see the deficiency tag, you can go right in the book and look at the deficiency. Same thing with hazardous areas. So we're again an existing chapter, Chapter 19. If you were new, you'd be Chapter 18. And you go to Section 3.2.1 for tag K321, and you'll see what hazardous area requirements are. So it's another good reason to have the book, and make sure you're opening up and saying, okay, this is what we need to do to what we got cited for. This is how we can fix it, and it's a really great help. There will be some that it doesn't work out for, but for the vast majority of all the tags, it does work. So a lot of folks know that with the 2012 came a lot of things with decorations and open kitchens and things, but there's a lot of other requirements that a lot of folks are not familiar with. And the one was they added fire-retardant-treated lumber can be used for installation of fixtures and non-combustible and limited combustible buildings. So if you have a building that is concrete, steel and those types of things, and metal studs, a lot of folks were worried about using wood in those buildings, and you can as long as it's fire-retardant-treated wood. You could use it for things like kiosks, handrails, things of that nature. Inspection of doors and testing. This one has been one that has been tough because NFPA 80 requirements are extremely strict on door clearances. So this is something that is newer. Started January 1, 2018, and you'll see it's not just closing and latching the door. You'll see pictures of the lady that's the top left. She's looking at clearances. The gentleman's checking on the right the self-closing hardware, and then the gentleman at the bottom is checking the clearances at the bottom of the door. So there are lots of things that we have to look for. The important is that it's fire-rated doors. It's not every door in your facility. Typically, your fire-rated doors will have a fire-rated label, but it does apply to new and existing installations. Here we're looking for the annual test and inspection. You need to have the written record, and it's more of a comprehensive document. It's not just Charlie checked the doors today, and everything was fine. There's going to be a lot of information we need to add that we'll talk about here shortly. So it's functional testing by knowledgeable individuals. So it doesn't say that you're required to hold a certification, although there are some classes that are out there. So if anybody wants some contact information on some of the classes, or some of the folks are saying, wow, an hour and a half of emergency preparedness and life safety code update is a really long time to be listening to that type of information. I've been through the door certification class. It is a 2-day class on just doors. I am certified now, but I will tell you that there is a lot more about doors that I never knew about. So there is information out there on becoming certified, but like we were saying, tested by knowledgeable individuals. It could be somebody on your own staff. They just need to make sure that they're familiar with how, if we go in and interview and say, how did you test the astragal in the store, and they tell us, what is an astragal, then we're going to question, whether they should actually be testing that door. And then you'll see repairs made without delay. We always make the joke with, Amazon, you make the order, and then the drone flies the door in, they drop it off your door the same day. It doesn't happen with fire-rated doors. A lot of times it takes a long time to get the doors in. So that's where we need that written record up above. We're talking about being a comprehensive document, because your repair could be that, it's just going to start with getting the funding, ordering the door. Here's who we ordered it through. Here's when it's supposed to come in. Because sometimes when you have to order a door, it's not that you can just fix it that same afternoon. So some of the things that you're looking for, no holes or breaks, if there's any glazing, no visible signs of damage. Right? Nobody runs a cart or wheelchairs or anything into your doors. Obviously we know that that's not true. It happens quite a bit. And then, there are some times when everything can be perfectly fine that morning, and then today is a high humid day, so some of our wooden doors might swell and then have a hard time closing. So it is really, we understand it's a struggle, or somebody could come through and, really do a number by banging in the door and doing something where something could be broken. So it's something that's really have to be vigilant on. No parts are missing or broken. Door clearances are appropriate, and there is information on what the clearances should be if anybody would like that. You can ask me, and I can send it to you. The one that's really difficult, it says no field modifications that would void the label. That makes it very difficult, because pretty much what they're saying is you can't do anything to the door after it's installed unless you call the manufacturer and make sure it's okay. So once you have these fire-rated doors, if you want to change the latching hardware, or do something different to the door, put a full-scale piano hinge in where you had just other hinges before, those are field modifications that you really have to watch out for. So there's similar requirements for horizontal sliding and vertical sliding and rolling doors. I keep this slide in here because Healthcare Interpretations Task Force is a group, state agencies, Joint Commission, CMS, other authorities having jurisdiction, and they try to get together once a year at the NFPA meeting and in the summer and discuss certain issues that there are certain issues out there that they want to discuss, to put out an interpretation so that everybody's surveying to the same standards. And the one that came up was doors. So we'll go to the next slide first. So is it permissible to remove the label on a fire protection rated door that is installed in a location where you don't need a fire rated door? So they say yes, you can remove a label, but you cannot cover a label. And the reason why I add this slide is because before nursing homes were sprinklered, a lot of people will have 20-minute labels on your corridor doors to all of the resident rooms. So by NFPA 80 code requirements, even if you have a 20-minute label on the door and it's a fire-rated label, you're supposed to be maintaining that as part of your maintenance program. Any door that's fire-rated. So some of these doors are no longer required to be fire rated because now you're fully sprinklered. So this is an option that we put out there. If you have questions about doing this or worried about doing, taking labels off of doors, I would highly recommend at your next survey, or if you have somebody that that you have come in that does the fire door maintenance for you, have them take a look at the doors before we just remove labels, to make sure that that's definitely something that you can do. They also talked about generator remote stops for certain generators. This is more for your type 1 and type 2 generators. So when we're sitting outside, that they're saying that you can put the remote stop on the outside location, but typically that's something we'll do more at the install of the generator. NFPA 10, which is the for your fire extinguishers, changed, and it requires that the folks coming in to do your annual testing be certified per NFPA 10 principles. So not only when they come out and do it and they're checking all your extinguishers, you want to make sure that you get their information saying that they have a document or some type of certificate saying that they passed the NFPA test. A lot of companies at first were trying to say that somebody in their office is certified and then trained everybody else, but they didn't have any certificates or anything like that. This is a class that is available online, so we're looking for not somebody you got trained and train other people that are going and doing it, but the actual people that are doing your testing, your maintenance on site to have that certification. It does not apply to the monthly quick checks that you can have your own facility folks do, but the annual tests, we need to make sure that they're certified or have some type of record that they passed an NFPA test for NFPA 10. They clarified in NFPA 10 that the remote cooking, so the satellite cooking kitchens that we have, if we're doing cooking there, that we need to make sure we have a Class K extinguisher at the satellite, not just the main kitchen. So a lot of times in the past, we might have had the ABC extinguisher, but they want to make sure we have the special Class K that's meant for cooking fires, even at the satellite cooking locations that we might have in our long-term care facilities. Privacy curtains. So real quick, we went from pretty much 18 inches down to 22 now. So this deals just with privacy curtains and just with new ones. So we don't expect you to go in and replace all your existing privacy curtains with the new 22 inches of mesh down from the ceiling, or if you want to, some folks might not have mesh, they might have chains or what have you, but going forward, it has to be 22 inches down. So if you renovate a wing, you go out and we're going to spruce up the units, we're buying all new curtains and privacy curtains. We want to make sure we get the ones with the new mesh at the top that is 22 inches down. And here you see it says newly introduced cubicle curtains, so it's not your existing ones, but anywhere where we introduce a new privacy curtain, cubicle curtain, we want to make sure that it's now 22 inches down. They did a bunch of tests. They found that 18 inches wasn't helping the sprinkler, keep the fire from spreading. So they found better results when it was 22 inches of mesh down or chain down, just so you have the curtain down 22 inches. Does that apply to everything? No. Everything else is still 18 inches. It's just that they put in the change for the privacy curtains. Receptacle testing. So you're going to see, we talked to, sent some special questions into NFPA, and they said it does, these sections do apply to resident rooms, even though they say patient care rooms. So there's going to be some requirements in here. Sorry, it's a little small for hospital grade, but also for non-hospital grade. The difference really is if you have hospital grade, rather than annually, you might be able to develop a program where you can go longer than annually. But the idea is at least once a year for resident rooms that we're doing receptacle testing. That includes the physical integrity, continuity, polarity, and retention force. So risk assessments are in the Healthcare Facilities Code, and what we're going to do is what this is. At first, CMS was telling everybody they had to go to every single system, medical, gas, power, HVAC, plumbing, and then say, is it category 1, 2, 3, or 4, with category 1 being something you can cause, if it goes out, is there a risk for major injury or death, whereas 4 would be virtually no impact. But they came back and said that it's just for new work. So if you're doing something new, you're replacing a generator, you're renovating your nursing home wing, for that new work, we're going to use those categories. And the reason why they have the categories is, depending on what category you fit in, the requirements are different. So if you're category 1 versus category 2, maybe a vent unit versus maybe just a rehab unit, then the requirements are more stringent for somebody where if they could possibly have some major injury if the ventilation stops working. So a lot of folks are very familiar with all the changes at the F-tags and the health world, but with that first big comprehensive review of the long-term care regs since 1991. But what happens is that a lot of folks have missed that there were some changes to the physical environment to resident rooms. So it's something I really want to go over, and this is really not for your existing ones, but it's existing facilities that are coming in for renovations is where we're finding this. So you'll see that 4390E, so in black, it's the text you'll see it says each resident room must be equipped with or located near toilet and bathing facilities. That's pretty much the old text. And then in red, you'll see the change. For facilities that receive approval of construction from state and local authorities or newly certified after November 28, 2016, each resident room must have its own bathroom equipped with at least a commode and sink. So you see that the big change here is that we're going from anything after November 28, 2016, if you're coming in and you're doing kind of some reconstruction work where we're not just doing painting or replacing fixtures, maybe we're adding a room, we're taking down a wall or those types of things, each resident room then has to have its own bathroom, and we can't share a bathroom. And then in addition to that, you'll see here, that previously it said accommodate no more than 4 residents, and then if you receive that approval after November 28, 2016, bedrooms must accommodate no more than 2 residents. It's something where if you have a 4-bedded room and you come in for renovations because we're renovating the wing and we're knocking down walls and moving things around, then we're going to have to, we can't keep the 4-bedded rooms, we're going to have to go down to 2. If we're just painting, replacing some curtains, those types of things where it's just minor work, they're really, you'll see it says construction or reconstruction. And when you get into reconstruction, this is the CMS didn't define it, but here's the definition from the Life Safety Code in the new Chapter 43. And it talks about reconfiguration of a space that affects an exit or a corridor, reconfiguration of space where you're not permitted in the space while you're doing the work because your means of egress is down, your fire protection, maybe your sprinkler systems are turned off so they can do the work in there. Something where you're doing more of that work, and there's some examples in the book of what work that fits into. And then here's some floor plans where you can see this is something that's very common in nursing homes. You have either 2 or 4 beds on one, or you have 2 beds on one side, 2 beds on the other side, and then you have the shared bathroom in the middle. But here's what we're saying, that coming in new, if you're doing something that fits under the reconstruction plan, then what CMS is saying is each room has to have its own bathroom with a commode and a sink at a minimum. And sometimes when you do that, you'll see in this plan, then you're going to end up losing space, obviously, and then you have to make sure that you have enough space for 2 beds, and in this case they didn't. They had to go to single beds. So it's just definitely something to keep in mind as you're renovating your existing facilities or you're building new. Anything that comes in now will be using those definitions and changes from CMS to review those plans. So what we're going to do is quick go over some top 10 deficiencies from January 1 to December 31, 2017, and then try to leave some time for questions. If there's any questions we can't get to, I promise Wendy that we'll collect those and we'll get those back out to everybody, distribute through email to make sure we answer those questions. So corridor doors, you'll see that. Sprinkler system, subdivision, which is the smoke barriers, electrical equipment, building construction type and height, hazardous areas, general requirements other. No, that doesn't mean we can just cite you for anything we want. We'll talk about what that means. Vertical openings, means of egress, gas equipment, which is your cylinder and container storage. Corridor doors, it's like we were saying before, there's something that they could all latch and be smoke tight in the morning, and then something could change, or we have somebody that knits a nice little thing with the family's last name on it and puts it around a brick and then uses that to hold the door open. So it's definitely a program that we have to to keep an eye on to make sure that corridors are being maintained. Here's a classic example of not only can you put a door wedge at the bottom of the door, but we can find all sorts of ways to use wedges, or you put them in the side. But in the end, you're really putting a lot of stress on the hinges, which is hurting your maintenance engineering staff who have to take care of the doors. Sprinkler system maintenance and testing. Really not too much to this other than the fact that we're just not getting it done in the specific time frames, or having the documentation on site readily available to show that we're doing the maintenance and testing. So it's something that I would really like to. It's one of those items you really like to see get off the list, because I think that's something we can definitely do. Subdivision of building spaces, smoke barriers. That's really where we break up your building into the defend in place. So we have the different smoke compartments. So you don't have to evacuate outside. So we just have to make sure that there's any doors in the smoke barrier, they're closing, they're smoke tight. All our walls are sealed up. And here's a picture of no matter how much we try to stencil our walls and label our walls, even though this says 2 hour instead of 1, so it's a little more. But somebody here ran conduit right through and pretty much right through the stencil and didn't seal it up. Some folks will have programs in place. Anybody works above their ceiling, they have to get like a permit to do so. However you manage it, we just want to make sure that those penetrations we cut down on. And just because it's a fire extinguisher doesn't mean it can hold open your smoke barrier door. That needs to go back on the wall. Electrical equipment, power cords and extension cords. It's really just the using it outside of its listing. We're not saying you can't use extension cords or surge protectors. There are temporary abilities to use extension cords, but it has to be just temporary, to maybe for a projector to watch a movie and then you're done. Or the surge protector is something we'll see on the next slide. For those of you that have pretty good eyesight, if you can read the sign, talks about don't use the microwave and toaster at the same time because they'll blow the fuse. That's kind of like one of those no crap ones. If you have that type of sign on your microwave, you're not using your surge protector properly. If you're using it at your desk for your computer, your phone, those are things you can do. If we're trying to make an impromptu break area and we're misusing them, that's something you're going to get cited for. Building construction and height. That's something where it could be lack of fireproofing or some of our older buildings that we're working on. Hazardous areas. We talked about rated doors and making sure that they close, not being held open again, and unfortunately they get held open quite a bit, where you see everything from gum and tape for the latch. K100, general requirements other. And what happens is there's so many life safety code requirements that they can't make a tag for everything. So this is one of those areas where it's a deficiency that just doesn't have a specific tag number. But it's also something where if somebody's doing renovations or construction without plans, that we'll put that as a deficiency there as well. Vertical openings, pretty basic as well. We're just trying to make sure everything's sealed up so we don't have the fire spread vertically. which is very dangerous. Means of egress. So here we're looking at dietary cards, soiled linen cards stored in the corridor. So that information went out about patient transport, being able to be in certain corridors, depending on how wide the corridor is, and making sure you have that program in place and you're training people. But that does not extend to everything that's on wheels. So that's patient transport and lift. So it still has the 30-minute rule on dietary cards, soiled linen cards. If they're there for more than 30 minutes, that's storage. If you're using the dietary card, taking the meals in, pushing it down the hallway as you go down, that's in use. If they leave it in the corridor, go take a smoke break and come back 35 minutes later, that's storage. So you'll see everything here where, on the left here, you got kind of a very sterile corridor. That'd be perfect. We understand that it's difficult to do, but we don't want it to look like the corridor on the right. We want to, understand that there's going to be, things in your corridor, especially with, having to be operational, but we don't want it to be jam-packed. It's an actual sign. Somebody did not want to put an exit sign on an outdoor gate. They did not get their occupancy for other reasons, but obviously we don't want to be doing stuff where we put any sign that says, to anyone who's too stupid to follow the sidewalk, this is the exit, just put the exit sign on the gate. This is something that's in the newer codes for dementia areas, but it's not adopted yet because we're still under the 2012. So a lot of folks want to do murals, very pretty painting, but that is not something that we can permit for exit doors at this time. Maybe CMS will come out with some information later through maybe like a waiver process, but that's not available at this time. And then what we have here is gas equipment, cylinder and container storage. So if the unsecured cylinders, full and empty cylinders not segregated, over 300 cubic feet being stored within a room that doesn't need oxygen storage room. So we talked a lot about, our shower rooms. After they're done, they seem to be the area that everything gets put into. So on the left here, you'll see that the showers were done, and then they decided to put some cylinders in there, but they're unsecure. So we need to make sure that we mark where we're going to keep our cylinders and keep them secure. On the right, it's one of those things where the rack only holds 12 cylinders. So you bought 13. What are you going to do? You just throw the other one on top? No. Go back and get that one at a later time. We don't want to have those types of situations. So it's something that you really have to be careful, especially once you get into these are the E cylinders, but you get into larger, H cylinders and things that you could really do some damage, or if it falls and it could hurt a resident. There's been, documentation of, where these things have become projectiles and went flying across the room. So we really need to be careful with the storage of oxygen cylinders. So that should give us about 10 minutes for questions, and then you'll see my contact information here at the end in case we can't get to your question or if you think of questions later.
Great. Thank you, Charlie. We really appreciate you sharing all this great information. Seems like a lot to keep track of. At this time, we'll open up the question and answer portion. If you do have any questions, please type them into the question pane on the right hand of your GoToWebinar screen. And Charlie mentioned while we're waiting for questions, Charlie did mention earlier in his presentation that he and Susan Williamson will be at our annual convention, and we'll have a session on Tuesday, November 13th at 3:45. So we'd love for you to come out if you're not already registered. Come on out. Tuesday, November 13th is considered our state day. There will be other state agencies in attendance, and we'll have sessions that day on Tuesday the 13th. And we'd love for you to get registered and know that rooms at Valley Forge are running on the low side. We are having a great response, so get your reservations made as soon as possible if you haven't already done so. We expect to be in overflow here pretty soon into September. Again, type your questions in. I don't have any questions coming in at the moment. I think Charlie did an awesome job going over everything. Again, I'm not quite sure how y'all keep track of it all, but there's a lot of things to know, and Charlie did an awesome job presenting today. Know that I will be sending an email with Charlie's contact information, a copy of the slides, certificate information, and a link to the survey, and also to the webinar recording later today. So keep an eye out for that. Give it just a couple more minutes here. If not, we'll wrap up and give you a couple more minutes back in your day. Again, any questions, go ahead and type them in. We'll be answering those. And if you have anything you think of later, I'm sure, again, we'll have Charlie's contact information for you in the email, so you can feel free to reach out to him directly. All right, I'm not seeing any questions. So everyone, have a wonderful day. Thank you for joining us today, and keep your eye out for other PHCA webinars coming up. We've got one on OSHA on September 6th. We have another one on CHC contracting on September 20th, and then we have a what you need to know about the upcoming November elections. And what you need to know, our own Zach Schamberg will be presenting on October 30th, and we'll be adding other webinars in the meantime. So keep your eyes out for those. Great. Have a great day, everybody. Thank you so much.